everybody, it's Miss Rachel with iCode Academy today. As you can see, I put in a new background. I'm really happy with it. Since we are unable to travel with COVID, I thought this is the only way I can get my little, airplane window in. So I'm just going to go on a little adventure here with you guys, and we're going to talk about coding for colonoscopies. Hopefully some of the tips in this video are going to help you get through coding for this procedure. Otherwise, if you have additional questions, as always, make sure you're reaching out for help and assistance, and our CPT manual is a great resource for that. All right, let's get started. By definition, a colonoscopy is the examination of the entire colon from the rectum to the cecum, or the colon, small intestines, anastomosis, and may include examination of the terminal ileum, or the small intestine proximal to the anastomosis. And so here you can see that we do have an image off to the right hand side, which reflects typically where the colonoscope with the light in the lens enters through the rectum and then continues on up through the colon. So let's talk about the different types of colonoscopies. You may have heard some of these terms thrown around, but I would like to discuss them a little bit more. So here we have a diagnostic colonoscopy, which is performed when there's an abnormal finding, sign, or symptom. So if a patient comes into the clinic and they have a chief complaint, such as maybe a hemorrhoid or diarrhea, abdominal pain, or rectal bleeding, the provider is then going to put in an order for a diagnostic colonoscopy. The other two types are screening as well as a surveillance colonoscopy. Now, a screening colonoscopy is performed when a patient has no symptoms, and an order is to test for the presence of colorectal cancer or perhaps polyps. Now, regardless of the finding of the screening examination, this does not change the intent of the order and the initial colonoscopy. So if they go in there, if they find cancer, if they find something that worries them, this is still a screening colonoscopy because there were no symptoms. It was just the colorectal screening that was placed. Now, a surveillance colonoscopy is, again, a patient who is asymptomatic, so no signs, no symptoms, there's no, complaint of abdominal pain or rectal bleeding. And this is done at intervals, typically about 10 years from their last colonoscopy, typically for high risk patients. So maybe if you have colon cancer in your family or if you're a certain age, that's where they're going to do that surveillance colonoscopy. All right, let's look at some definitions within our CPT book. If you're using the 2020 AMA CPT coding manual, this is going to be on page 334. So here you can see the definitions for sigmoidoscopy, colonoscopy, as well as some details regarding a colonoscopy done through a stoma, and therapeutic colonoscopy. We're not going to go through all of this right now in today's presentation. The one thing that you want to keep in mind is, again, let's make sure that we're reading the resources available in our CPT coding manual. A lot of times there's additional information in there that is valuable to you. All right. So here, when you take a look at your screen, I want to review a few things for you. If you're having trouble determining if something is probably a diagnostic colonoscopy or if it's considered surveillance or a screening, this tree may help you. So here you can see whether the test or the procedure was done, whether there's a history in the family, are there any signs or symptoms that resulted in this referral, was the term screening used? So this is going to give you a little bit of guidance as far as the difference between determining if it is a surveillance, diagnostic, or a screening colonoscopy. All right, I also want to pull up the colonoscopy decision tree. If you Google colonoscopy decision tree. There's going to be a few different versions that are floating around there. And you also have a version that is reflected in your CPT manual. And so here we can see that a patient comes in and the provider says, you need a colonoscopy. Now, the provider is going to determine if it is therapeutic or if it's going to be a diagnostic colonoscopy. This decision tree is really going to help you as far as your code selection when it comes to how far the procedure went through the colon, if it reached the splenic flexure, if it went all the way to the cecum, how far the procedure went. And that's going to help you determine if it is a full-on colonoscopy or if it is going to be considered a flexible sigmoidoscopy. And then if you need a modifier or no modifier. But again, this decision tree and then the one in your CPT coding manual is not going to help you determine whether it is diagnostic, screening, or surveillance. But it's just going to help you determine your appropriate code selection depending on how far the procedure went through the anatomy. So let's talk about the difference between a colonoscopy and a sigmoidoscopy. Here you can see from your image that if the scope advances through the entire length of the colon, which we enter here through the rectum where we have in green, and if it goes up through the entire length of the colon, this is where we're going to stop for a sigmoidoscopy. It's evaluating only the lower third portion. Once we continue on past this and reach the hepatic flexure and continue to go down, now we are in the realm of a colonoscopy. So keeping our anatomy in mind is going to be extremely important for coding these procedures. So let's talk about some of our diagnoses codes that we're going to be using as far as our screening colonoscopies. Follow-up colonoscopies are surveillance and not screening. If a screening is the service performed in the absence of signs or symptoms, only the patient has a diagnosis of polyps, whether they're hyperplastic or if it's serrated. But an exam can be reported as surveillance colonoscopy if the patient has a history of polyps and they're now returning for a follow-up examination. But otherwise, they're asymptomatic or they don't have any complaints or signs or symptoms. We want to make sure we're picking up Z86.010, which is that personal history of colonic polyps. And this needs to be reported if there is a history of previous benign polyps. Otherwise, we do have an additional two options here, our Z12.11 for the encounter for screening for malignant neoplasm of the colon. And again, these are for our screening colonoscopies. We also have our Z80.0, which reflects that family history of a malignant neoplasm of the digestive organs. So there's some options available to you. I also want to talk about the ICD-10 codes associated with the NCD, or our National Coverage Determination, for colorectal screening tests. So here you can see, in addition to our personal history of colonic polyps at the bottom, the Z86.101, as well as our other Z codes for family history, we do have additional diagnoses such as K50 for Crohn's disease. We also have K52.1 for toxic gastroenteritis and colitis, as well as Z15.09 for a genetic susceptibility to other malignant neoplasms. Now for our non-Medicare payers. Our non-Medicare payers, just to list a few, we've got Cigna, Humana, United Healthcare. Here we can see the appropriate CPT codes that we may be utilizing. So we've got our 45378 for our colonoscopy. We also have codes for biopsy, hot biopsy, if there's any stent placement ablations, as well as any band ligations for hemorrhoids, whether they're internal or external. One thing that I want to point out is 45378 at the top of our list, which is our colonoscopy, is the base code for a colonoscopy without biopsy or any other interventions. So if a brushing or washing is completed and performed, you want to make sure that you are adding the additional codes as necessary and reflecting those on your 1500 or claims form. All right, let's talk about modifiers. Modifiers that we may be utilizing when coding for colonoscopies. The first one is going to be our PT modifier. PT modifier indicates a colonoscopy was scheduled in a screening as a screening, but was converted to diagnostic or a therapeutic procedure. Next one is going to be 33. 33 should be appended to preventative services when the primary purpose of the service is to deliver is the delivery of evidence-based services. All right, next we have 53. Our guideline Medicare state that if a patient is scheduled for a screening colonoscopy, but there's poor prep and the scope cannot be advanced beyond the splenic flexure, the code that we should be using is for the colonoscopy, but adding a modifier 53 on it for a discontinued procedure. So again, typically what we would do is if we stop at the splenic flexure, this is going to be a sigmoidoscopy. But the intent was to do a full colonoscopy, but the provider could not complete that procedure due to poor prep from the patient. So that's why we want to go ahead and add the 53 because we did not complete, or the provider didn't complete the colonoscopy as intended. Next one is 74. 74 is going to be our modifier that we use for discontinued outpatient procedures after the anesthesia has already been administered. So in this case, we're going to append this to the colonoscopy if the documentation reflects that they did not make it to at least a transverse colon. The documentation does need to state why the procedure was stopped or discontinued. Sometimes maybe there's a complication or the patient is too uncomfortable and they stated, this, we need to stop, I can't continue. We're going to add a modifier 74. The next one's going to be our modifier 73. This again is for a discontinued outpatient procedure prior to anesthesia. So if the anesthesia is started, but the colonoscopy was never started, this is where we're going to add 73 to the colonoscopy. All right, let's talk about some frequently asked questions. One scenario that I've heard of that I wanted to bring to your guys' attention is, what if the provider in his documentation notes, patients complaining of rectal bleeding or they're complaining of abdominal pain, but then they're going ahead and providing a diagnosis code as well as an order that reflects a screening colonoscopy. What are you to do in this situation? What you want to do is make sure that you are going based off the documentation regardless of the order that the provider put in, and this would be coded as a therapeutic colonoscopy. All right, I hope that cleared up a little bit of the questions that you guys had as far as coding for colonoscopies. Thank you so much for tuning in today's presentation. I'll see you later. Bye-bye.